Okay, good evening, everyone. I hope you're having a good day. So we're going to start now. We have a few participants, so we'll start the webinar now. So today we're going to be talking about the role of interdisciplinary collaboration in modern healthcare. And our speakers are Dr. Aisha Mustafa and Dr. Abosede Lewu. Okay, please, can anyone see my screen or can you hear me? Can anyone hear me?
Clearly, we can see your screen.
Screen, okay, thank you. So we're going to be talking about the role of interdisciplinary collaboration in modern healthcare today. So it's a very important topic in healthcare, and the purpose of this topic or bringing this topic to the front line is that there are a lot of gaps when it comes to collaboration, from gaps within doctors, gaps among doctors rather, and even among doctors, nurses, and other healthcare professionals like therapists, dietitians. And the point of talking about this is the main purpose is by increasing collaboration or fostering collaboration among healthcare professionals, we'll have better patient outcomes. And the goal is basically to ensure that our patients get the best. So collaboration in the form of more discussion, in the form of utilizing technology as well, just to ensure that we foster collaboration among ourselves. So today we've invited multiple healthcare professionals, from hematologists, gynecologists, oncologists as well, family physicians. And the purpose is to discuss how we can improve collaboration among ourselves. And we've also invited people from other countries like the UK, the US. So it's a way to compare collaboration in Nigeria and also see how collaboration is done in these other countries and how we can improve collaboration among ourselves. So our first speaker for today is Dr. Abosede Lewu. She's an obstetrician and gynecologist. So she's a trained obstetrician and gynecologist. She's an administrator, policy and public health expert with over 20 years of experience working in various sectors with both local and international organizations. She's an alumnus of various prestigious institutions like Harvard, University of Lagos, and University of Maiduguri. And she also has a postgraduate fellowship. Sorry, she earned her master's in public administration from Harvard, her postgraduate fellowship from the University of Lagos, and her medical degree from University of Maiduguri. So Dr. Abosede Lewu, please, you have the floor.
Can you hear me? Hi, everyone. Can you hear me?
Yes, ma'am, we can hear you now.
Okay. Thank you so much, Débbo, for inviting me to speak. You guys are always trailblazing, and I always appreciate the opportunity to share platforms with you because you guys are living the collaborative ethos that we're going to be speaking of today. So when you sent this to me, I mean, generally when people reach out to us as doctors, people usually reach out to us to speak on our own area of expertise, which in most cases is usually the medical degree that we have. So whatever area of specialty you have in, that's what they usually call us to talk about. So when I saw this topic around collaboration, I was really, really intrigued that, yes, this is something that needs to be brought to the front burner, especially with the peculiarities we're now experiencing in the healthcare service delivery. So, Dr. Graham, I wanted to confirm, should I just free flow, or you want to ask me questions, or we should make it conversational? Just give me a heads up on how you want it to go so that I can take it from there.
Okay, we want it to be conversational, Ma. Yes, so
Okay.
just free flow and conversational. Yes.
Okay.
Yeah.
So great. So one of the first things I did when I saw your topic was to look for like different definitions of collaboration. And what stood out to me was that it's, regardless of where you checked it out, it talked about partnership, union, working together to produce something with someone. And it usually takes two or more people. And then the next one that I found most interesting was it said that with the intention of it producing an outcome that is better than what would have been produced if you had worked in silo. So what does this mean? When there is collaboration, the output should be more than what individually the parties that are collaborating stand to achieve together. So when I saw this, I thought to myself that what's the best way to address this? I'm talking to health people that work in the health sector. And I thought, let me break it down into how do you collaborate with your colleagues, your peers? So let's say you're a doctor, how do you relate with your consultants, you relate with consultants, medical officers, residents, medical students, house officers. It cuts across. So that's how you relate with your colleagues. How do you collaborate with them? The other one is how do you collaborate with other healthcare professionals that have their own different cadre? How do you collaborate with pharmacists? How do you collaborate with your nurses? How do you collaborate with your lab technicians, lab scientists, anesthesiologists, like anybody that you're working with that is not in your own current cadre? How do you collaborate with them? And then the third part that I divided into is how do we collaborate with organizations? And when I say organizations, how do you collaborate with other healthcare service providing organizations? And how do you collaborate with non-healthcare service provider collaboration? So sort of in my mind, that was how I looked at this topic, that I would like for us to talk about the collaboration that happens between us as colleagues and peers, the collaboration that exists between us and other cadre and of healthcare service providers, and our collaborations with organizations that we have the potential to work with. Apart from the way that I sort of want us to talk about it from my own perspective, are three values that are very important to me. So I say values, and I'm going to be sort of repeating it. One, wherever you're operating with as a healthcare professional, how valuable are you? So this is a combination of how much value do you have and how able are you to deliver when people need services. The second part I'll talk about is how well do you value others in the field? Do you think that in your team or the people that you're working with, you are the most valuable and every other person's value is diminished? So the value is two-way. How valuable are you and how well do you value others? The final one is, even though it's valuable in two different directions, the last one is respect. How do you respect your colleagues? How do you respect other cadre of healthcare service providers? And how do you respect the organizations that you interact with, whether they're in the health sector or not in the health sector? So, Dr. Graham, I'm going to hand it over to you now. Do we ask questions? I hope you are all listening to me, because you said it's going to be conversational, so I'm going to pause here. I hope you've been able to hear me since I've been talking since.
Yes, Ma, I can hear you clearly. I can hear you clearly, yes. So, Yes, so it's going to be conversational. So please, if you have any inputs or anything you would like to say, please, you can unmute your mic or you can drop them in the chat box for Dr. Abosedilewu as she speaks.
So if I see any question, I'll just pause in between and then jump into it. So when we talk
No
about
problem.
how we as healthcare workers, and I'm going to start with the one of us relating with our colleagues. And I know that especially if you went through the residency program, even if you didn't, you know that there's a lot of hierarchy in medicine. So one of the problems that I find that makes collaboration challenging is most times the hierarchy that we're used to from either those that are senior to you or those that are junior to us. So one of the things I'll say is that if you have an open mind to collaborate, do not let hierarchy be a barrier to that. For those that are really more experienced and very high up in the medical field, most times when you present yourself properly and then you seek collaborative opportunity or you provide it to them, they are willing and able to engage with you. For the younger colleagues, I always tell people that the Gen Zs have really been very pivotal in how I have grown personally and professionally. So we should also be open-minded to even those that are maybe we're higher down in hierarchy in the medical field. It also, for us to collaborate effectively, another thing I've noticed is that it takes a lot of open-mindedness to learn and unlearn how things were done in our time or how things were done in the past. And we have to realize that the current realities of 2024 are a bit different from what it was 10, 20 years ago for some of us. Another one is to also be very truthful. So I went through this process myself when I was thinking about setting up where I work now, which is, do you think your team members or other caterers that you work with think you respect them? You have to have a very honest conversation with you. How do you provide your own collaborative platforms? Do you just talk down to people? Do you just instruct people and you expect them to follow? Do you give room for feedback from people that ideally don't want to face you and talk because maybe you're older, you're the one paying their salaries? Do you create a safe or brave space for your team to genuinely collaborate with you? Or are you dictating to them and they're simply following you? So I think when we're talking about collaboration, it is critical for you to know that being open-minded and being honest with yourself is very key in knowing how you can effectively achieve collaboration. Another thing I always say is that for us to also embrace and actually appreciate collaboration is to do the numbers. It is better to have 10% of a million than to have 100% of 1,000. Culturally, I think we are very interested in ownership. We like to own things. We like to own ideas. We like to own organizations. Like, it's who we are. But a lot of times, how much can you do alone as a person? And when you know that if you be 1% of a big field, of a big ocean, sometimes it's bigger than being 100% of a small bucket of water where you're operating from. Another thing I would like to sort of chime through is, what will it benefit you individually? So let's say we are now, one of the things that Dr. Gayemi said was that one of the reasons why we should collaborate is to give our patients quality healthcare services. I 100% agree on that. But there are other reasons why you should collaborate. How does it benefit you as a healthcare professional to collaborate? So yes, the output is that your patients get better care, but you as a person, how does it benefit you? So first thing is, it gives room for better ideas. Two heads that are genuinely better than one. Sometimes someone that gives you a simple solution that you didn't even think about. So it's an opportunity to get better ideas. And we've already talked about work outputs. It also reduces burnout. For doctors, especially those that run multiple shifts or you're in a surgical field, you know that burnout is inevitable. You'll be tired and then you'll be exhausted, but it's just you, you're pushing through, you're trying to be the surgeon, you're trying to be the administrator, you are the HR, you're not collaborating on anything. It is going to provide room for us to have burnouts. So when you collaborate, you actually reduce the chances of burnout. When you strategically collaborate, you also earn more. I found that as doctors, one of the greatest challenges we have is to actually own the fact that we want to have money because of the humanitarian nature. And I think it's not only doctors, generally everybody in the health sector, is that medicine is so non-moneyed, you have to put people first. But you also earn better when you collaborate strategically in a way that allows more work to be done. And also, in the big picture, you learn new methods. And I always say that when you collaborate, you're making the health sector stronger, and you're also helping to keep more health workers in the system. We all know that there's a huge brain drain happening everywhere. But with collaboration, that gives opportunities for people to earn more, for people to be more fulfilled. It is very important to know that collaboration has financial implications and even infrastructure and systemic impact on people that are already working in the health sector. So let me quickly go to actionable points, especially when I talk about values. I've talked about how valuable you are. Another thing that seems to, for us as healthcare workers, we tend to focus on is that, my value comes from maybe hierarchy, like I said, maybe you did residency, you're a consultant, you're a professor. But I will tell you that there are levels of ability that you can have that has nothing to do with your clinical skills. There are skills that young people that are not specialists bring to your team that even you will find out that, wow, I didn't know I could do all of this. Some people bring tech support, some bring admin, some are very innovative, some are good networkers, some have networks that they use to bring business into your own space as well. So how valuable are you as a healthcare worker? Like if they took away your certificate today, what is in you that people are going to be willing to pay for? So that is very important. Now, I also say, how well do you value others? Now, this is one thing that I struggle with when it happens, because for me, over the last 5 years, I've genuinely stopped it, is how well do you value your doctor friends, nurse friend, pharmacist friend? Because I find that a lot of people keep sending free, like some people send people to talk to me, and those people expect it to be for free. And these are not indigent patients. Sometimes by the time you spend 5, 6, 4, 3, 2, 3 consults to your friend, you are not showing that your friend's skill is valuable. So maybe once in a while, you can do the free one, or sometimes you pay something. I find that that is also something I always say that, see, if you're sending someone to a fellow consultant or a fellow medical officer or a fellow resident, please do not expect them to share their knowledge and skill for free, especially if you're not sending them an indigent patient. It's a different thing if you're sending them the patient to a government hospital and you say, okay, just see this person. But if you want them to consult in private practice, please, let's put value, financial value on the money. You want the nurses that work with you, everybody that works with you, you're sending people to them to work to provide services for free. It doesn't show that you value them as much as you should. And I always say that for each time you do that, you're contributing to the brain drain indirectly as well. In fact, some of my friends know me, there's a particular amount of money that you can't charge less than that if you are in this cadre, except for indigent patients. And I also put a caveat that if you are consistently sending your colleague indigent patients, you are also not helping. Indigent patients are meant to go to government hospitals that services are relatively affordable. But if you have friends that are in private practice and you consistently send indigent patients to them, you're not collaborating with them. You're generally just sapping their energy, and you're not helping them with growth, and you're not collaborating effectively with them. Another thing I talk about collaboration is most of us, when we studied what we studied in the health sector, I feel like a lot of us did not know why we chose to be doctors. Some people it's because you were brilliant, some people it's because your parents wanted a doctor in the family. But there's a particular point in time where you get to where you now begin to know that you should know why you are doing what you're doing. And you should also know what is valuable to you at the point you are in, because this drives the need to collaborate effectively within the health space. So what do I mean by that? As a medical doctor, how much money, and I don't mean an infinite, arbitrary, or bogus figure, how much money do you need to earn to be okay? And I don't mean to be wealthy. Now you ask yourself, how much work do I need to do to earn this money? Is there room for collaboration to bring in this money? And this brings us to the partnering with organizations, not necessarily medical organizations, even non-medical organizations. So you have to have that honest conversation with yourself. I think I always say that one of the curriculum that is missing in medical school is entrepreneurship and financial literacy. A lot of us don't genuinely even know how much the medical school cost us, and we don't know, we know the fixed rate that people pay doctors, but you have to know a doctor that has an extended family that relies on him, or a nurse or a pharmacist, is different from a medical doctor that came from a family that inherited wealth. So you should have that conversation with yourself as to how much money do I need and how can I spread my wings to get this money? What are the collaborative opportunities that can improve my earning power? We also talk about, like I said, we should be uncomfortable talking about money. So I'm going to wrap up so that Dr. Aisha can also take it from here. I'm going to say 5 action points that I want us as healthcare workers to always know that there are skill sets that can up our collaboration game. Communication. We must communicate with each other effectively and respectfully, regardless of the cadre of the person you're talking to. Even people that are younger than you, people that are working under you, deserve respect. Maintaining relationship. Networking and relationship will take you to, will open so many opportunities, so many doors and opportunities to you. So maintaining relationship with people, keeping it respectful, and checking in with people is very important. So communicate, maintain relationship. Embrace technology. A lot of things, the world is online. There is nothing like, oh, I don't like technology, I'd rather do one-on-one. No. You can do one-on-one, but technology has come to stay. And look at us, we're from different parts of the world and we're talking on a technology platform. Social media. The good thing about social media is you can do it any way you want. If you're a serious person, you can be on LinkedIn. If you're a funny person, you can be on TikTok. If you have bulletproof or violence, you can be on Twitter. Just pick one of them and be a voice. You already have the knowledge. Share, let people know about you. Sometimes you have no idea who is looking at what you're saying and how that can be an opportunity to collaborate, to earn, and to deliver more, better services. Stay innovative. I always see that for us in the healthcare sector, because it's such a core professional field, some of us, outside of what we practice in medicine, if people ask us, we're like a fish out of water. We should learn. We should innovate around even the medicine we know. We should continuously kind of get information that helps us as doctors to be innovative. So whether you're working in government hospital, whether you're working in private practice, innovation is the key to the future. How can you do things differently? How can it be that when people talk about you, people say, people do this like this everywhere, but this doctor here, this nurse here, this physiotherapist here doesn't do our own this way. And I'm going to close up my own part by saying that when I saw this, I was like, this is a very good way to talk about collaboration. None of us is as smart as all of us. So the more, the merrier. So I'm going to hand it over back to Dr. Bayemi, and thank you all for listening to me. And if you have any questions, please, I'll be in the chat to read through them.
Thank you so much, Dr. Abosede. You made some very, very interesting and important points. Like, for instance, you mentioned communication, which is very important. And you also mentioned maintaining relationships as well. I think when you maintain relationships, it also makes collaboration easier. For instance, if you have a friend, for instance, in another discipline or something, I feel like it can be much easier when you already have a relationship to simply reach out to get ideas from them, to ask questions, maybe concerning a patient's management or something. And also you mentioned technology as well. Technology is also very important. I feel like technology is also a very easy way. So it facilitates the process of collaboration. If you have electronic medical records and everyone, for instance, can easily access that, it makes collaboration very easy as well. So we have some questions here for you. Would you like to take them after, or do you want us to just continue with you before we move on to Dr. Aisha?
I can take the questions, that's fine.
Yes. So someone is asking that how do we get access to, so for instance, where you have like big teaching hospitals and you want to talk directly to, say, as a consultant to a dietitian, like in those kind of big organizations, how do you easily get access to those people without sending consult? I think what the person means rather is that consults can be like a form of barrier, like it's a long process, for instance. So how can you easily foster collaboration, say, between a dietitian and yourself as a consultant, or a physiotherapist, or a mental health therapist as well, like in a big institution?
Okay, so thank you so much. So when I was a resident, this was a big problem for us because in O&G, most of the medical cases we have usually require multidisciplinary approach, including dietitian, especially when we started having a lot of PCOS cases. And like you said, the consult habits was not easy to follow up. So as a house officer, of course, you take consults, you wait for feedback. But as a resident, I remember vividly the first time I actually went to a dietitian's office. It wasn't even for a consult. I literally just went to their office to see the people that were the dietitians that we had during that time, because we were really having a lot of PCOS cases. And I was able to speak to one or two of them. And from that conversation we had, we exchanged numbers. And then I find, in fact, till now, I still talk to now that I'm out of residency, I still do some work with some of those dietitians. What does this mean? Beyond the consults, the fact that, in fact, the day I went to the office for the woman, and I said, I came to greet you. I'm a resident in Obs and Gynae, and we're always sending patients to you. Even the process of following up, them giving us a feedback is also a whole long process. So I'd like to know how you work. That was the day she explained that these are clinic days. This is how we do our work. And by having their phone numbers, even when I sent consults, I could always follow up with a phone call to sort of make access easier. In fact, that was my sort of methodology to residents. Like, by the time I send consult once or twice to you, I must know a doctor in that department, so that talking to them will be, I mean, it's going to be like, hi, yes. So I just send a consult. Before the consult gets there, they're already anticipating your patient coming. Also, it still boils down to respect. When you go and look for other specialties and review patients with them, you're not loading information. Sometimes you do a discussion with them and they're like, oh yes, you hear their inputs. It also makes them feel very valued and respected. And that kind of affects how the information travels between you and the other person in the other field. So the first time, the consults are not going to do it. They don't know you. They're just one extra letter from like 50 letters they get in a week. But once you establish contact with, even if it's one person in that department, it makes communication and working together easier. So I did that a lot across different departments. Most of those people that we did residency and work together, we're still friends and we're still colleagues still now. Can you hear me?
Yes.
Okay, all right. I'm waiting for the anchor to re-anchor me back in.
I think we probably lost her.
I think so.
Sorry, can you see me? Sorry, my network got off.
Yes, we can see you.
Yes, we can see you now.
Okay. Yeah. Can you see my screen as well?
Yes.
Okay. Yeah. So sorry. Yeah, so I didn't get everything you said, but we also have another question. But I got a bit like a snippet of what you said, something little about you dropping going to meet the dietitian yourself and how that fostered like a relationship between you and the dietitian up till now as well. Yes. So apart from collaboration among doctors, I know nurses are also very important when it comes to collaboration, because if you don't, they're usually the ones on the wards, and they give medications, and I feel there's still that gap between nurses and doctors in terms of that communication, communication between them. And I feel like if you don't communicate with a nurse, say for instance, your treatment plan, that can delay the patient's treatment. So how do you think we can also foster collaboration between ourselves and nurses as well?
So I find that because I am now fully in private practice, is that
yes.
Teaching hospital, you are living in a cocoon. And because teaching hospitals, we have backup doctors. Like if the health officer doesn't work, the medical officer doesn't work, the resident works, the consultant works. If the NO doesn't work, the CNO works, the ADNS works. When you go out into the real world, you begin to know that you are underutilizing your relationship with the nurses that you work with. And this still goes back to what we say, that when you think the only thing that a healthcare professional brings to your practice is their clinical skills. So when we talk about care for patients, I've seen some of my senior colleagues in residency do it. They're doing ward rounds. You know how we know how ward rounds go. There's a senior person talking, asking people questions. Ask the nurse on the round what she thinks. what people co-create, they have a stake in it than what you tell them to do. That is one of the things I've noticed. So even in my own private practice, we do have nurses. We have something we don't call it a ward round, we call it a sitting round. And then we throw out the problem, like this is the challenge we're having. This is the medical condition we're managing. It's not like I don't know what I want to do. And I'm asking them so what do you think we should do about this? I'm going to give you an example. So we recently managed a woman that is trying to conceive, but she's a bit on the older side because we use a bit of supplements. And I remember that I just told her that let's use the dosage we used for the last patient. And then she was like, oh no, doc, the last patient is 24. This woman is 36. I think we should use the maximum dose because our response may not be as quick as that of the younger person. For me, I was like, that's a good point there. Let's do it together. Assuming the first patient we gave, I'm just scribbling down and passing to them. You will not understand that she's applying a clinical acumen as well to your patient management. So I say that if you want to foster a relationship with any cadre of healthcare workers, it still boils down to respect and value. What value do you ask for their opinions? Do you ask for their input into whatever you're doing? It may not even be clinical. Like, we want to set up this thing. What do you think about this color? We want to do this conference. What do you think? How can we make this conference better? It's all about making people part of the co-creation process. And this sort of make them become stakeholders. Again, it makes people feel respected, that you're not just giving them information as someone that has more knowledge than everybody in the room. It's like everybody is chiming in and it keeps everybody interested in whatever you're doing. So for me, that has been my experience, that even some of my senior colleagues that always used to carry along the nurses, there was always a more robust conversation and a better service delivery to the patients. Me again.
I think we lost her again.
Dr. Goyemi, are you back? Okay.
I think you're muted. We can hear you.
Can you hear me now?
Yes, we can.
Yeah. So I was saying those were the two questions we had for you, and thank you very much. And you made an important point, especially when it comes to like nurses and doctors. You said one person's, like the knowledge of all of us is more than the knowledge of one person. And that's very apt because, you can't feel like you know it all, or you don't have anyone's support or anyone's like wealth of knowledge. And, sometimes people tend to underestimate other people from other disciplines. They think, oh, doctors are paramount or their knowledge is paramount, and like, why should you be asking a nurse for her opinion? But the funny thing is that actually the nurses that have like years of experience, you find out that they even know from the things they see on the ward, because in the end they see a lot of things on the ward from different specialties. Like they see a lot of things that happen. They are exposed to different treatment plans as well. So sometimes they might even have like more knowledge on certain things than we do. So it's important to, discuss with people from other disciplines and, get ideas from them as well. So thank you so much for your presentation. It was a lovely one. And, we got some, we're able to learn one or two things from you. Thank you so much. So we are moving on to Dr. Aisha Mustafa now. So our next speaker is Dr. Aisha Mustafa. She's a consultant in the gynecologic oncology unit of the Ahmadu Bello University Teaching Hospital, Zaria. She's also a senior lecturer at the Affiliate University. She's involved in the clinical care of gynecologic cancer patients, in addition to teaching, research, and advocacy for prevention, prompt diagnosis, and evidence-based treatment in Nigeria. She's the founding member of the Transatlantic Gynecologic Cancer Research Consortium, a member of GOSON, NSCCP. Okay, I don't know what this means. And she's a pioneer secretary of the Cancer Health Fund for Gynae Cancers at Ahmadu Bello University Teaching Hospital. So Dr. Aisha Mustafa, over to you.
Hello, good. So much for inviting. Very good talk. I don't know, my network will probably get unstable. It's raining here, but just let me know if you can't hear me, then I could try to change position. So thank you very much. I listened with so much rapt attention because I mean, collaboration in the health sector is so important and cannot be overemphasized. And it's actually very important when we use real life situations to bring out the importance of interdisciplinary collaboration, which Dr. Abosede did a lot in her talk. So I will go through this outline and I'll just, as a form of introduction, next slide, please. I just want to reiterate or for emphasis, say that the collaboration doesn't just occur between me as a doctor and my doctor colleague. It doesn't just occur between me as a doctor and other colleagues in the health sector, like the nurses, the physiotherapists, the dietitian, as Dr. Lewu mentioned, the maybe clinical oncologist, the medical oncologist. You know, there are just so many fields in medicine that at one point or the other, we will tend to need their collaboration to improve patient outcomes. So it actually brings about experts or different units from various fields to tackle complex issues. And research have shown that when patients are managed in collaborative teams, in multidisciplinary teams, they actually tend to have better outcome than when they are not. So this helps to develop holistic solutions to very complex issues that patients might have. Now, even within one health institution, for example, those of us that work in a teaching hospital, especially pioneer teaching hospitals like ours, you find almost every subspecialty within the hospital, but sometimes that is not even enough, that you have to go in between hospitals to collaborate. And one can collaborate for different reasons. Is it for more knowledge, for more experience? And sometimes it's not even for the knowledge of medicine, but you're collaborating because of availability of a particular skill, a particular equipment, a particular treatment modality. So for example, for those of us in cancer care, you may actually be collaborating with a different institution simply because your LINAC machine is down and you cannot give a patient radiotherapy, for example. So for us to be able to administer comprehensive care to patients, then collaboration is almost inevitable. I don't ever think it is possible to manage a patient from start to finish without collaboration if we really want to do a very great job. And we're hoping that the collaboration will actually improve the patient's quality of life or dignity in death, if that is the final outcome. Next slide, please. Okay, so I'll still talk about the role of technology. We know that in multidisciplinary teams, or if we work in interdisciplinary teams, depending on the type of collaboration that we are doing, we know that what is very important is that within your colleagues, that's for those that are working in a team of many doctors, then there should be collaboration within the doctors, then within different healthcare staff, as I have mentioned, especially the nurses. Doctors and nurses are the most frequent collaborators on healthcare, even though we know that other specialties are also very important. Now, apart from the collaboration within humans, it is also very important in this age, just like how Dr. Liu mentioned, that technology is applied. Technology does not just make it easy for collaboration. For example, it is standard all over the world that no cancer patients should be seen without an MDT. So we must do an MDT meeting for every single cancer patient, simply because cancer is a very complex treatment process, and one person can definitely not treat cancer. So it is now standard, even the Federal Ministry of Health have made it mandatory that every cancer patient must be seen by multidisciplinary team before her treatment starts. And even during her treatment, then she should be seen periodically by multidisciplinary teams. And these multidisciplinary teams will actually depend on the type of cancer that she has. This is just an example. Now, because of the frequency of the MDTs that we have, you could just finish an MDT now and another new patient comes. It is almost impossible to call for a physical MDT at every point in time. So initially we're doing a mix of physical and hybrid, but recently we have almost completely transited to hybrid, to virtual meetings. So we use a lot of Zoom, Teams, and even Google Meet to do the MDTs, such that these patients have a documentation of a treatment plan, and then everybody also knows it. So yes, the use of telemedicine is also very important, and these virtual care platforms that are upcoming now, here is Débbo. This is a very good example of this. So this doesn't just help facilitate communication, it makes it faster, it makes it easier for the teams, and it also makes everyone at the same time know the outcome of the meeting. If, for example,
Sorry, I think Dr. Aisha's network, she mentioned her network is poor. So I'll just reach out to her now.
hello. I'm so sorry. I honestly don't know what happened. I kept changing location and changing network. I apologize. This happens all the time nowadays. I don't know. So I don't know where I went off, but I was talking about utilizing virtual platforms so that the entire members of the multidisciplinary teams actually know the plan the patient is having at the same time, not waiting for one healthcare professional to finish seeing the patient and then a consult is sent and the patient is booked for another clinic day of the other healthcare professional. So, for example, another role that technology can play in actually fostering interdisciplinary collaboration is the use of EHR, that's the electronic health records. We all know the initial paper system where we have to document on the folder. The patient has to go to the pathology lab to get her histology result, and then the result is now taken to the clinical oncologist or the gynae oncologist. But when there is a functional electronic health record, at the same time, once a patient's results drop, then every member of that team can be able to access the record. So this actually helps to streamline information sharing and definitely improve continuity of care without any delay. Then there are lots of mobile health applications that are actually coming up. And for us in gynae oncology, we also use a lot of artificial intelligence. For example, even cervical screening now, you can actually use AI platforms, and you can just take a picture of the cervix and you do not know what you're seeing on colposcopy. You are probably not very experienced with colposcopy, but artificial intelligence has made it really simple. There are now numerous apps that we can use for cervical screening and pre-cancer treatments, and some of them are free. In fact, most of the ones we're using are free. We use the Aviva app quite frequently, and it was even one of us that contributed to its development. So yes, artificial intelligence is actually very important in collaboration. Another thing we do a lot, especially with the Survey app and the Aviva app, is that when we go into the community and train healthcare workers. For example, we train community health workers to actually use the app for screening, and they may not understand what they are saying, but because remotely we can all see the cervix they are screening, so we can always put responses in the app. Okay, this is a normal cervix. Don't worry about what you're seeing. That is just an ectropion. No, this is not abnormal. This is not normal. You need to treat, So the technology actually makes us have even the remotest access to these patients that are probably hundreds or thousands of kilometers away. And that way they can actually have care comparable to those people who are actually within or close to the teaching hospital. So these are some of the applications of technology in interdisciplinary collaboration. Next slide. The challenges, I think the greatest challenge is actually that resistance to change. I remember vividly back in 2019 when I returned from my first fellowship in the UK, and I actually saw how the MDTs worked. So after my training and after taking the very big decision to return home, I thought of it that what are those little things, those little changes that we can actually make back home here in Nigeria? We know, well, I can't come back here to do robotic surgeries like I was doing there, but what are those little things that we can bring to make patient care better? And I thought of starting the MDT, and in May 2019, that's exactly 5 years ago, we started the MDT on 13th of May. It was a Monday, and the greatest challenge I had was resistance to change. It was so difficult. Why do I have to call a urologist? I mean, we know what to do. Are you saying we don't know what to do, Aisha? So it's very difficult, especially people believing that you're actually better off as a collective than as an individual, no matter how experienced you think you are. So yes, I didn't put that down, but it is my own personal greatest challenge for commencing interdisciplinary collaborations. But now, 5 years on, because it is now normal, the same people, my same teachers, will now tell, you mean this one's not had an MDT yet? What is happening? So with time, it was a very slow, gradual, and very frustrating process. But alhamdulillah, now they actually have all seen the benefit and how the patients are doing much better and how easier it has been for us with these collaborations. And now they are the ones even propagating it. So funding was a big challenge. It is usually a challenge because it is not easy to bring different specialties together, and even institutions. It is definitely cheaper if one person is doing it. But because we know one person is not adequate, then we need the funding for the collaboration. And of course, if there is limited communication, which we definitely had in the beginning, and some people are not even joining, what are they going to discuss there? And if there is no coordination, another big challenge we had is the doctor still had to do the job of the non-doctors. Let me give an instance. In the UK, if there is an MDT, there is actually an admin staff who pulls together all the patients' EHR numbers, all the images, the MRI, the CT scans, the laboratory results, they do it. But back here in Nigeria, because we don't have a staff, or rather in my own institution, we don't have a particular staff that does that. It had to come back to the doctors. So the doctors had to work more in order to make the patients benefit from the interdisciplinary collaboration. So that was initially a very big challenge, the one for coordination. And of course, just like how Dr. Lew said, the hierarchical structures. So it's usually very difficult sometimes, even when you want to make a contribution, simply because your professor has said something, you don't want to say something else. So we usually have that, and it takes a while before we actually learn how to communicate within our colleagues who are our seniors. And at the same time, we're also learning how to listen to our colleagues that are our juniors. So another thing is we just start the collaborations and we just say, okay, let's start MDTs, let's have an intern. Everything needs training. In fact, I underestimated the value of training until I went abroad. I had to be trained on how much soap I will use to wash my hands. So it is so important that we just simply overlook it. So I think there is need for training and retraining about interdisciplinary collaboration, its advantages, how these advantages can be overcome, its benefits, and so on. Next slide. So yes, we've had some challenges with interdisciplinary collaboration, but how do we address them? This is one way of addressing them, this talk. So, I mean, it's something that I really wish we're able to disseminate the information even more, bring in other colleagues, younger colleagues, probably older colleagues, to come and hear about it and then interact and then hear from them, their own perspectives, their own proposed solutions, and how we can as a collective actually improve collaboration within the health sector. So moving forward, I'll really hope that we can share the flyers early, and then we'll be able to get to our other colleagues to be able to join the meeting. So if we can implement or continue to implement such education programs such as this, we'll actually be able to enhance our communication and our teamwork skills. And very importantly is to establish clear roles, because I did all the administrative work then. I'll just get somebody from radiology say, why have you not come to collect the MRI results and the MDTs tomorrow? It just became like it was my job, and everybody just saw me as the admin staff. Meanwhile, I was just volunteering to do it. So there is need to establish very clear roles. I was on the MDT as the gynae oncologist, and there was also a clinical oncologist and a radiologist, but everybody just saw me as the administrator because I was doing all the admin work and I wanted the MDT to succeed. So if we establish very clear roles and actually employ or get somebody to do the administrative work and the IT work and not put the burden on somebody who is supposed to be a clinician, then I mean, that will help, because it will just make people get frustrated and say, okay, I'm not even doing it again. So this is very important for our roles to be very clear. And then it's also important that we promote a culture of respect. It is very important to respect other members of the health team. And I could resonate very well with what Dr. Lew said. And when you go to discharge a patient at the bedside, don't just say, okay, she's fine, her vital signs are stable, she's eating and drinking, she's weeing and pooing, okay, she's ticked all the boxes, okay, discharge her. No, that's not how it's done. One will have to talk to the nurses who sleeps with the patient every day in the ward. Matron, what do you think? Can this patient go home? And then she begins to tell you, in the night, she had restlessness, I don't think. Then you listen to her, and that way she feels like a member of the team. You don't come for ward round and spend 2 hours, the nurse is just following you around and you did not even talk to her once. Honestly, if you come back to the ward, she's not going to follow you for that ward round. So promoting a culture of respect, mutual respect, and not this, oh, we're the head of the team, so you know everything. No, nobody knows everything. And honestly, we can learn from everybody. So once we understand that, and we know that other health care professionals have a lot to bring to the table, then there'll be this mutual understanding and respect among team members. And very importantly, there should be regular interdisciplinary team meetings and case discussions. So these are some of the ways I thought that we can mitigate some of these challenges that we have. Thank you very much. Next slide. I'll be very happy to take any questions if there are.
Okay, thank you so much, Dr. Aisha. I have a question here. Are you still on the call?
Yes, I'm with you.
Okay. So someone is asking, how do you mentioned that when you started the MDTs, you used to have there was like an initial resistance to change. How do you how are you able to forge ahead or like through that resistance? How are you able to move through the resistance to the other side of success, basically?
Yes. Thank you for the question. Yes, it was a bit difficult. So whenever I called for the MDTs, my senior colleagues, they trained me. Now I'm working under them. Even though I was also a consultant, but I was much younger than them, they felt, why do you have to call the urologist? Is it that we don't know what to do? So they felt slighted, thinking that the collaboration simply meant that we don't know what to do, come and tell us what to do. So what I actually did was I reached out to my mentors at University College London, where I trained, and I made them give us a talk at the hospital level. So I went to the CMAC. There is something that we call hospital presentation. So I actually asked for that and they gave me a slot. So they made a hospital presentation, made it so important. They told them that, in fact, here in the UK, you can never treat a cancer patient without MDTs. And we started. Then just in 2024, this year, the Federal Ministry of Health made it compulsory that no cancer patient should be treated without MDTs. So I think if they heard it from people who they feel are their superiors, they will tend to believe it more than you, who is just their trainee, and they say, okay, is it just because you've gone to the UK and want to come back to tell us what to do? So I think that also helps, that you just shouldn't be the only driver for that change. If you're more than one, or you have other seniors, or you get people that have been doing it for many years and you invite them to speak to you, I think that will actually help. But that actually broke all the problems we had with commencing, and we're able to commence. And then we even had hospital support. They gave us a multi-head microscope, laptop, venue, generator and everything, just to make the MDTs work. And they kept using the gynae MDT as the gold standard of MDTs. And even when other MDTs are failing, they say, go meet the gynae MDT and find out what they're doing. So it became really important. Even the nutrition is that the only thing we did with them was to send patients to go and buy Kwashi pap, which was like a fortified pap we use for malnourished children and cancer patients. But when we started inviting them, they felt so important. They felt really happy about it, and they contributed a lot. And honestly, we learned a lot from their expertise. Things we thought we knew, we actually didn't know, but they knew and they told us. So it's actually a win-win situation for everybody.
I like what you said about your story about MDTs also highlighting the importance of collaboration among institutions. I mean, initially when we brought up this idea, it was just about collaboration just among healthcare professionals, but it's highlighting the importance of also looking at what other people are doing, being able to collaborate with them as well to bring about change. That's very good. Then also another question is, I know you mentioned something about nurses and wanting them to feel that mutual respect. I feel like there's already this bias in, say, like a lot of nurses' minds that maybe, I don't know, I don't want to say this fight for superiority, but yeah, that you don't respect them. But how can you make a nurse feel that mutual respect, feel respected, feel that her opinion is valued, and she's so that, I mean, because if someone feels like their opinion is valued, it will make them want to feel free to make suggestions, and collaboration will be seamless. So how do you make them feel that's value, that's their opinion is valued, and when they make that suggestion, you take it on board?
Yeah. Thank you very much. It's a very good question, because yes, we all know that there's this health sector rivalry, you know, there's this workplace issues that we're having between doctors and other healthcare providers, especially nurses. But honestly, when I look at it, especially from my angle as a medical politician, I do a bit of medical politics, and we see these issues. We see even workplace violence between doctors and nurses, and I feel it's really uncalled for. And this is something that is very easy to overcome. And honestly, the way to overcome it is by just respecting them. They just want that respect. You know, there's this belief that you just see somebody, maybe just a newly graduated doctor, probably thinking that because it's the doctor, then the nurse is inferior. No, you don't see any healthcare worker as inferior. No, because without the nurses, there can't be a hospital. And without the doctors, there can't be a hospital. So if you're both important for the hospital to work, then you should give each other mutual respect. But for me personally, what I do is, I know that if I want my work to be easy, then I need the nurses on board. Because it will frustrate you if you bring them aboard. So honestly, like going into the ward, just greeting them, hello, matron, good morning. Please, matron, can we start the ward round now? We are making them feel like, matron, it's only when you're ready that this ward round is going to start. So they say, oh, Dr. Mustafa, don't worry, let me finish taking my tea, I'll join you, you know. But when you just say, matron, we've started ward round, honestly, it's going to be different. She's not going to come. And there is nothing you can do about it. And then the wahala starts. So it's just that respect that every time we get to a patient, I will ask, matron, please, who is the relative of the patient? Who do you trust among them? Who should wait? Even when I know the answers to these questions, sometimes I still put it to them. So I think that probably works. And then, of course, I don't know most of them's names, but I just call it, oh, sweet matron, sweet nurse, you're looking beautiful today. Can we have a word round? It just makes it's easier, you know, just a lot of interaction, communication. And sometimes you ask them questions, you know, the answers. The answers are very obvious, but you're just asking them because you want to make them feel very important in the team. And then you find out that at the bedside of a patient, a nurse has contributed 3 times. She will want to go to the next bed because she knows she's important. But when you don't ask her any questions, she's not saying anything, the next time she's not going to join you for the ward round. So honestly, I think it's just our personal interaction with them. And I keep telling my junior colleagues, you know, all these Aluta doctors, they say, we are the head of the healthcare team. I said, do you know how to prove that you're the head of the healthcare team? Knowledge. Just prove it by knowledge. You don't have to say it, you know, let the knowledge speak, you know, and you don't have to just take a mic and announce that you're the head of the team. Your knowledge will make you the head of the team. Absolutely. Okay.
Thank you so much. Someone is saying it is a global problem. So considering the fact that you were in the UK, did you notice any, or have you noticed any difference like between the UK setting and the Nigeria in terms of collaboration? Like you noticed
there's a very big difference. Because honestly, it's so difficult to tell. Well, the nurses are super knowledgeable. And when I worked in the UK for about 2 years, you know, I had a license to practice. So I was seeing patients and I didn't understand anything. I will see gadgets. I didn't know what they were. I saw a patient with a yellow thing, pushing it around. I didn't know it was an epidural. I saw another one with a white thing. I didn't know it was a PCA. There were no doctors around to ask. It was the nurses I was asking. Please, matron, come and teach me how to do this. You know, they'll just put 1 drop of blood in one machine and 1 paper will come out and they understand what are you analyzing, you know? And they tell you, oh, it's the lactate, is this, is that. I had to learn everything from the nurse. Why? With humility. And then, of course, I go back to read these things. And yes, I had the theoretical knowledge, now I've seen it practically. So I got better with the nurses. And from there, I realized that we have a lot to learn from these nurses. So honestly, the rivalry is not as bad, definitely. Though there are still some subtle rivalry here and there, but it's not as bad as Nigeria. And I feel that we can all work towards reducing health sector rivalry by just giving our colleagues that mutual respect that they not only crave, but they deserve. They actually deserve it because they are actually very hardworking group of people. And, you know, celebrating them on Nurses Day. On Nurses Day, I carry a placard, I wear a uniform. I join them. I say, yay, it's our Nurses Day. You know, so they just love you because you are recognizing them, or should I say, you're working with them. You're identifying with them. You know, so things like that. Just these little things matter, and that is what I think. But yes, it is not as bad as it's not as bad as it is here in Nigeria over there in the UK. Over.
So I have a question for Dr. Abosede. Dr. Abosede, I know you have a private practice. Would you say it's easier to collaborate like like in that setting, that private setting, compared to say a teaching hospital? Do you think is it easier with nurses and even with doctors? Do you think it's easier to collaborate? Because I know some private hospitals compared to teaching hospitals where you always have like a specialist like available, and then in your private practice they might not always be around. Like, which do you think is harder or easier?
So it depends. Thank you so much, Dr. Aisha. That was very, very insightful. I got quite a lot of points from there. And so, I mean, I meant it's a global thing, as in that hierarchy thing is there. But one of the things I find that we struggle with as a people, and when I mean as a people, as Africans, as Nigerians, is not knowing how to infuse our cultural and traditional norms into practice. We are a respect-driven culture. But we want to do, so I like when I traveled abroad as well, I struggled with calling my professors their first name. I still can't. I will put the prof before the name. And I will see 18-year-old, 21-year-old go and say, hi, Fred. Fred is 70, like Fred is 65. There is not, everything inside me resists calling Fred his first name. Like I even had to, just using sir and all that. It took a while to drop all that. But as I've grown older, there's nothing wrong with that, because to the core of who I am, we are meant to respect our elders. And I think that is what really happens between nurses and doctors. Doctors are churning out more young doctors, and older matrons are the ones that are left. And you find that these matrons knew you as a year one student. They knew you as year 2 years. They knew like literally through your medical life. And then suddenly, because you earned a degree, you start speaking to them in a way that goes against the core values. And that's why you hear things, offensive statement like, I'm old enough to be your mom. This is not how you talk to your mom. This is not how you talk to an older sister. So that respect thing again is in being very culturally aware and sensitive to where you are operating in. When you enter and people are sitting down, it is rude in most of our culture to just walk in and jump. They are the ones running the world. You just walk in and then you start saying, give me cotton, give me. You are being rude to them. It's not about you being a doctor. It's about you being a rude African child, basically. And that is what they resist in you. It doesn't matter how much knowledge you have. Once you, like that thing she was saying, if you say sweet, no, sweet, look, they will go over and beyond. A nurse taught me how to do sutures. Like I can remember vividly. I was a copper then. She was the one that built my confidence. Till now, she's a senior nurse with Lagos State. If I'm doing any circumcision, if we're doing anything immunization, she's our go-to person. So back to clinical practice, I think it's very difficult to make a broad statement, because in every unit, there are people like Dr. Aisha. Even when that collaboration is not there, you'll find those consultants that actually embody that. And you literally see doctors, nurses, lab technicians, lab scientists, blood donation, blood bank, behaving differently to one unit than another unit. They're all in the same space. So you can't even say collaboration is not easy. The most difficult matron, you will see her with one doctor that will say, doctor, how are you? Can I know your patient? I will give you all this thing. When we did not see your house officer, we called other house officers. They've administered everything. Patient is okay. Don't worry. Go and sleep in your call room. Same person, same ward, 2 patients side by side. So you can't make that broad statement. Now in private practice, because it's quite small, except if you have a huge practice, whatever comes from the head trickles down into the organization. So if you as a leader in a private practice create these respectful boundaries, it's very difficult for people working under you to act out of order, because it looks a bit different. Also, collaboration is easier, like she said, when roles and responsibilities are documented. There is a reference point. That was something I learned a bit the hard way, where things are not assumed. Things are concretely written, and there is like a manual you can go back to reference that so, and so says there. Another thing that I found make collaboration easier for us is having a conflict resolution component of your organization clearly spelled out to everybody without any conflict. So things like when there is a conflict, these are the steps to take. When you're angry, is that minute? When you're angry, you are allowed to take so number of minutes to step out of that situation and cool down. All of those things, people don't assume that people understand what you want to do. Make sure it's documented. So I don't think there's a hard and fast rule. And I've actually also seen some private practice that are borderline dictatorial, like nobody can breathe in the private practice. So it's all about who's in charge of the team, really, that determines the level of collaboration and how much value that person puts on collaborating. If you want to be the alpha and omega of your private practice, people will let you be. If you want people to work within your private practice, people will work with you, but it's the tone that you said that people follow. But in government hospitals, you meet a mix of everything. It's a cocktail, and hopefully you'll be in a better unit than like Dr. Aisha's unit, so that you enjoy yourself.
Thank you so much, Dr. Basili. Thank you so much.
And I'm sorry, I wanted to chime in something. Sorry, Dr. Gayemi. The question you asked Dr. Aisha was, how do you make the nurses feel important?
You've muted yourself, ma. Dr. Basili, you've muted yourself.
How can she make nurses feel important? One very powerful thing I noticed about her was that she did not tell you how to make them feel important. She emphasized to you how important they are. And it's you recognizing. It is not making them feel important. It is you acknowledging how important they are that matters. It's not a feeling, it's a fact. And that's why she said they know they are important, and it's very disrespectful when you don't acknowledge it.
Thank you so much. Thanks so much. That's a very important distinction between, if you say you're making them feel important, it's like, oh, they are not important, but you're just trying to make them feel that way, versus, you're actually important, and we're acknowledging and, emphasizing the fact that you are important. So we have we have Dr. Anu raising her hand. And I'm happy you're raising your hand, Dr. Anu, because I wanted to come to you, but I wasn't sure if you were ready or willing to speak. So please, you can unmute yourself and speak.
Thank you so much. I hope you can hear me.
Yes.
Thank you. And thank you so much to the speakers. I learned so much. I'm a general practitioner based in the UK, and I have a special interest in women's health. I would have done obs and gynae, but I didn't like the surgical aspect of it. So I think my question is for, in fact, both speakers, and especially Dr. Aisha, because she mentioned she worked in the UK. What role do you think? Is there any room for collaboration between maybe general practitioners? Because I know in Nigeria, family medicine is a bit different from GPs here. But is there any role for collaboration that you can see between general practitioners like myself, maybe who have a special interest in women's health, and maybe in private practice back in Nigeria? So I don't really mean among other healthcare professions. I just mean with, collaborating with gynecologists, for example. Are there any, is there any role that you can think of that GPs might have with, gynecologists back home in Nigeria?
Thank you very much for that question. And I think, yes, there is a very big role that GPs or family physicians can have with gynecologists in Nigeria, especially in terms of, I apologize, I'm in oncology, so I always use my examples from oncology. In terms of screening, for example, absolutely, the family physicians and as such, the women actually go to them first. And for example, cervical screening. And then very importantly, we noticed that there is almost like an epidemic of ovarian cancers in Nigeria. In the past, you will spend a whole year and you just be counting ovarian cancers on your hand, less than 5 or 5. But now it's an epidemic. In the last 1 to 2 years, it has overtaken cervical cancer in my institution. It's so huge. And what we found was that these women were not being diagnosed late. They were being recognized late, meaning it wasn't late presentation, but late detection. So these women will have gone to our colleagues, doctors, but they'll be treating them for peptic ulcer disease because, as we know, ovarian cancer is something that has very non-specific symptoms and very gastrointestinal symptoms. So they will have been battling ulcer, which is peptic ulcer disease, for maybe 2 years. They've been taking so many medications. They've been seeing the family physician or the internal medicine specialist. And then it is much later when the disease advanced that somebody does a TVS and finds an ovarian mass, or when the ascites is very evident. So we started by creating like a collaboration. How can we identify these women earlier? So we started concentrating on our colleagues, of course, it's not, we, the specialists, might recognize it earlier because that's our field, not because so we started talking to them, and then we formed like a team with the family physicians in the community. That's Tudumada. Those of us that know Zaria will understand what I'm saying. And then whenever they see patients with these GI symptoms, they do not prescribe the PUD medications before they do a TVS. So to improve early detection. And at least we have seen 2 that have come at stage 1 from the family physicians because they did a TVS when they presented with ulcer, which is the peptic ulcer disease. So I think there is room for collaboration, honestly, a very big role for collaborating with family physicians. And of course, cervical screening, they do it routinely until when there is a problem, then they refer to us at the teaching hospital. So yes.
Thank you so much. Thank you.
Yes, I'm also going to chime that there's a big room for collaboration between family physicians and gynecologists. And I say this as someone that has actually observed in private practice the reversal of medical tourism. We've had quite a lot of people seeking care. We offer virtual services as well. And we have quite a number of patients from the UK that we're providing services for virtually. One of the bottlenecks that we experience, as you know, is navigating the laboratory systems in the UK. So how can a GP come into that? I have also been thinking about this. We have few patients, some of them have PCOS, they have fibroids, but the wait time before they get their service is quite long. So a lot of people have started receiving care virtually from abroad before they do finally come to Nigeria if they have to. So I think for a GP in the UK, there's room to collaborate with specialists beyond even gynecology in Nigeria, because quite a number of us are now having patients in multiple countries because of telehealth and virtual consultations. So I think if you have like I said, since you have focus on women's health, there are access to that. There are even examination. I've had a patient in Kano before that I was like, this one needs to be examined. I called the consultant, my friend who works in Kano, and she did the physical examination and did everything. I have a patient in Abuja. We're considering she should have a sacral. It was my colleague there that examined her. So when we have patients in UK as well, when we need physical examination, we need laboratory work so that it's the doctor-doctor conversation to make sure that we're having a cohesive care being delivered. Yes, there's definitely room for that.
Thank you so much. That's very helpful.
Thank you so much. So time is fast spent, but I am a very young doctor and I've learned so much from everything you've said. I think I've taken a lot of notes, and some of the important things I've learned or that I didn't think about that are very important is the collaboration among institutions, which was emphasized by Dr. Aisha. Maintaining relationships. Dr. Abosede has given so many examples of the importance of actually maintaining relationships and how that fosters collaboration. I mean, you're talking about how you can call someone in Kano, call someone here, call someone there, and that's because you have a good relationship with these people. Then also, you've also addressed how to overcome resistance as well. The importance of getting influencers, people who are well respected in that field, to be able to come in and, when they make a presentation, like it encourages them, because maybe they're able to value, not that they don't value you, but they respect the opinions of those influencers, because you've said you looked like a trainee to them at that point, compared to if the Minister of Health comes to. So those are like, maybe, I don't know if they're called major stakeholders, but the importance of people who have that great influence in overcoming resistance as well. Then the promoting a culture of mutual respect as well. That was also a very big one and cannot be overemphasized. Mutual respect among colleagues, seeing your colleagues' opinions as valuable, seeing the nurses' opinion as valuable, acknowledging that the nurses are important, acknowledging that your colleague's opinion is very important as well. And I also really love the example about how, like that example between a family physician and yourself, and how that has helped to, detect ovarian cancer very early. And I think that's very important because, I wonder how, for instance, I don't know if it's then important to be having those discussions regularly with your colleagues or to be setting up meetings. I wonder if that would foster more collaboration, because that's a very, very important example you gave, being able to detect, because that's a big one, because I also know that ovarian cancer is very sinister. And I think people present with symptoms when I hear that once you're even having symptoms of ovarian cancer, then it's already advanced. So the way that's being able to talk to family physicians and being able to, educate them on how to detect ovarian cancer early is very important. So that means beyond collaboration, education or awareness is also important as well. It's also a way of fostering collaboration. So thank you so much. You've brought in very important points, and we are very, very grateful for the wealth of knowledge you've brought in today. We really appreciate you taking your time out to give this talk. We're very, very grateful. If anyone still has any questions before we close, you can still put in the chat box. But anyway, it's already 6:30, and we'll be ending the symposium now, rather. Thank you so much, Dr. Abosede and Dr. Aisha. And thank you, Dr. Anu, for chipping in.
Thank you. Thank you, everyone.
Um,
Thanks for
thank
having
you.
us. Thank you.